Desplanny, Dr. Harmat, Dr. Mardikar, thank you for having me here. I'm pleased to be back here. And after the very exciting cases of Dr. Matthew, I'll come back to elective stuff. And of course, I have my own collection on catastrophes, and they do not always come out well. Sometimes you cannot resolve them. But let me take you back to 1977, and I'll show you very calmly the first ever coronary angioplasty in the world, where I have been a chance to be a part of. And this is the catheter with which the case was done, and it could easily be, of course, used. Could easily be used still nowadays. If you want to do a coronary angioplasty with this catheter, it would still be possible. It's not steerable, but if you reach the lesion, a proximal lesion, you could still use it. My role then was a very minor one. As you can see, I held groin at the end of the procedure. I still like to kind of put this caption, which is kind of cut off, but it says how I saved the first patient's life, because if I had walked away, he wouldn't have made it. Andreas Grünzig was the operator. Some of you still remember him. Now, at the time, and of course you have to have reached my age to remember that, visibility in the cath lab was nil. This is what you saw, so you couldn't really make up on just on fluoroscopy, and there was no replay, no still frame, nothing what was going on. You had to develop the cinefilm, which took about 20 minutes to know what was going on. So this is Grünzig with this first case in the original cath lab where the first coronary angioplasty was done, 1977. So pressure measurements, which have come back a little bit with FFR if you want, were quite important at the time. You can see that this was the initial stenosis of this young gentleman, 38 years of age, by the way, the same age as Grünzig had when he did the case. They were age mates. Now you can see there was a proximal LAD lesion that was not a spasm, because this the angioplasty was done 2 days after the diagnostic study, and there was still the same lesion there. So as a second step, you can see that the pressure distal to the balloon was measured. This initial balloon didn't have a through lumen for the wire, but it had a distal pressure measurement capability. You can see that the pressures were the same, a little more damped in the balloon than in the guiding catheter. Then going through the lesion, you can see that there was a pressure gradient caused by the lesion. And then during inflation, here the balloon is inflated, you can see that the pressure almost went down to zero, so there were no real collaterals at the time. Because if there were collaterals, the pressure would stay up at 20 to 40 millimeters of mercury. And then after balloon release, you can see that the distal pressure comes up and of course almost reaches the baseline. When you pull back the balloon, it will reach the baseline. It was the only way Grünzig at the time could judge that he had done a good thing, because in fluoroscopy he wouldn't see anything until the film then was developed, where of course he could also see that the result was quite pleasing. Now this particular first case had a pre-planned follow-up exactly 1 month after this was the case, and exactly 1 month later he had this initial follow-up, still showing a good result. Of course there were no stents at that time. I wrote the first report, as you can see here. I signed it, and it's in German, so you won't understand the details. It says it was on 16 September 1977, the first world's coronary angioplasty was performed. And interestingly for you, the patient was put on vitamin K antagonist. It was not yet known that aspirin could be used for anticoagulation at the time. Aspirin had been around for 70 years, but it was not yet recognized as a blood thinner. Just for your interest. Now this is the further follow-up of this first patient. This is again the initial lesion here in the circle. Here you can see that exactly 10 years on the day after the initial case, Andreas Grünzig, unfortunately, already had died in a plane crash by the time, but Spencer King had the patient come over to Atlanta for a elective follow-up angiogram during a life course. And lo and behold, this case in 1987, this diagnostic study was done by Spencer King himself using a 4 French multi-purpose catheter. So even at the time, you can see that you could do a coronary angiogram in 4 French, and the patient was up in the lecture room 2 hours after the intervention was done femoral, but even then outpatient coronary angiography was already quite a effect, and it was a 4 French case with a very good result here. See, the artery looks almost normal. And then this is the next step in this patient. I did an angiogram in 23 years later, and you can see it looks pretty good. But there was something in between. Now, what had happened in between? In April 2000, the patient who kind of had become a friend of mine because I did regular exercise tests on him, called me and told me that he was not feeling well. He said, I get similar symptoms like the one I had 23 years ago. So I called him in and I did this angiogram here, and you see there is a stenosis, not really, the initial stenosis was a bit more distal, but somewhere in the same era. Of course, I kind of hated the fact that now, after 23 years, this case was kind of failing. So I told him, that doesn't look very significant. I don't think you need anything. Although in any other case, seeing that, I would immediately have acted upon without any hesitation. But in this particular case, I talked myself out of it. So I sent him home saying that's not really a significant restenosis or new stenosis. But then just a few months later, or actually during the months, he kept calling me, said, I don't feel well, I get those symptoms, and I'm really not pleased that you're not willing to do something. So I called him back in again, and you can see that this lesion was still there. So I did my only FFR I've ever done in my life diagnostically. I've done it in some studies. I've never used FFR diagnostically, I never will. But in this case, I thought it was coming in handy because and you see, the FFR was normal. So I told him, you do not need anything because a normal FFR, this was in 2000, we already knew that the normal FFR actually told you that the stenosis was not significant. But I said, I'm having symptoms now. I've been here the second time this year. I want you to do something. So I had to do it. I put in a balloon, and this was the result after the balloon. And I told him, we're finished, everything is fine. But he said, no, we're not finished. Now everybody gets a stent. I want a stent. He looked at the screen himself. He was quite savvy in the meantime about coronary angioplasty. So I would have left it like this. He didn't want to leave it like that. So we put in a stent, and this was the result with the stent. Looked a little bit better, as we all know. And so he went home again, but it was only like 6 or 8 weeks when he called me again, and he said, listen, now I'm worse than I've ever been. You know, I can't walk 10 steps and I get angina. And I told him, maybe you should better come back in again. And lo and behold, he had an in-stent restenosis. It was a bare metal stent at the time, of course, was before the drug-eluting stent. So then, of course, I redilated this with a balloon, and this was then the result that I showed you here. So it wasn't as easy as it looked here. There were some detours to get there. And actually, the patient was kind of dismayed. He told me, well, you really haven't made any progress the past 23 years. You know, the first time in 77, I came in, had an angiogram, then Grünzig looked at the angiogram and he did the case the next day, and then I went home and everything was fine. Now this time I have to come in twice to convince you to do something, and then you do something and then have to come in a third time to correct what you've done. I mean, where were the progresses? But that was just kind of unfortunate follow-up. Now I'd like to show you something here which you may not be familiar with. It's called washout collaterometry, which we've done in him, and showing that at least at the 23-year follow-up, he did have some collaterals. Now, what do? You inflate your balloon, but while you're doing this, you also inject some dye. So as soon as the balloon is up and blocks the LAD in this case, the dye is caught. The dye is not going to be washed out. There's no blood coming from above. So the only way this can wash out is if there are collaterals from somewhere. here, of course, could come from the circumflex or from the right coronary artery. And if you keep that up for 20 minutes and you see that now the dye has completely disappeared in the LAD, not in the diagonal, you know there are good collaterals to the LAD, no collaterals to the diagonal. So this is a free assessment of collaterals. And if you let it run, you'll see it a bit more easily here. You can see that that blowing up the balloon, the dye is caught here, and now watch the dye or in the next 10-20 seconds. You can see that slowly but surely it is washed out by collaterals, which can come from the circ or from the right coronary artery, so you don't need a second catheter for the other coronary artery to show this. And you see the diagonal doesn't have collaterals. Of course, the circ collaterals you could show also indirectly by injecting now with the balloon inflated and showing the filling of the distal, but you can also assess the right coronary artery collaterals with this. Now, the story then went on. We're now 38 years after, so that was not the end of it. Now in 2014, another 14 years later, he again called me and said he had been in for an on and off exercise stress test. Usually didn't show up for 5 years before he came again for a control. But here he called me and said, I get the same symptoms again. I think you have to take another look. So I did take another look, and you can see the situation now had worsened a little bit. This was the initial site of Grünzig's angioplasty. This is about where I put my stent and redilated my stent. So it was somewhere, or maybe the stent was here, so somewhere between the initial lesion and the stent that I had put and post-dilated in 2000. And this again was the initial situation, showing that the initial lesion was a little bit more distal. So this is basically what Grünzig dilated. This is more my stent. The left ventricle is still normal. This is all done with a 5 French left Amplatz guiding catheter, which I use also for my diagnostic studies and for my angioplasties. And then this time I got a drug-eluting stent covering the entire lesion. He also had now for the first time some problem on his right coronary artery, which of course on the occasion was also fit with a DES. And this is then 6 months later he came for his routine follow-up stress test, and you can see that he does have a right bundle branch block, which he already had for a few decades, but he doesn't have any signs of ischemia any longer, and he is again quite fit and pleased with his overall evolution. Here you can see him 38 years when he had his first angioplasty. He was then kind of a star of the newspapers for a while as a new technique to treat coronary artery disease. And this is his last picture here with the bust of Andreas Grünzig from 2015. He's still enjoying a very active life. And this, of course, is all signed by Andreas Grünzig, my tutor. Thank you.